benign variant and they have responded to eculizumab, the preference is to stop the drug and to kind of watch them and see what happens. Then there is another category that might come back. You find a variant, and that variant is called a variant of uncertain significance. So now we don't know if it's pathogenic or benign, and I think that is the biggest unmet need right now to figure out what to do about these, what we call VUSs. So, there can be some functional studies that can be done to figure out definitively whether those VUSs are pathogenic or benign, and that's kind of the area that research needs to go into. But if that, suppose hypothetically research is done and that VUS comes back as, okay, this is benign, then we stop the drug. If it's pathogenic, we continue. Unfortunately, at this time, until we have that information, and if it is a VUS, some patients or most patients have to stay on the drug because it's kind of hard to take a risk of taking them off and then having the recurrence. In some patients who recover completely, we have taken that chance to take them off eculizumab because of two main reasons. One, or I would say three main reasons. Sometimes patients don't want to stay on the drug because it's an every 2-week infusion. It is very costly. And the third thing is that, even if they have a mutation, that by itself is never enough to cause the disease. There is always a trigger or a second hit that is needed. So almost all patients who present with aHUS have had something that triggered it. So either an infection or, sometimes transplant patients, if they've had a transplant, that was a complement activating event, pregnancy, something that triggered it. So we take the chance of taking them off the drug because unless they have another trigger, they probably will not manifest the disease. And there are more and more articles coming to the fact that if a patient has responded, they've recovered complete kidney function, you take them off the drug, and then if they were to have recurrence of aHUS, then if you treat them promptly with eculizumab, they will respond pretty well. Now, in those cases that will have a recurrence a first time or a second time, then those patients should probably be left on the drug forever. So that's kind of the working, that's how most clinicians or people are working this out.
And now this is news to me, and therefore it's very informative. How long is a patient normally on a drug? When you say you have this, you try if there's a complete remission, and then you eventually take these patients off the drug.
Right. So that's a good question, and there is no one number that goes with it. It's really up to the comfort level of the individual clinician. Sometimes 6 months, sometimes a year. Typically that's the range, 6 months to a year, they'll be kept on it. And if everything is looking good and the patient has a benign variant or does not want to stay on the drug, you take them off. That's typically the range, up to a year maybe.
But may I also infer from your statement that if you find a genetic variant, then the patient normally stays on the drug for a lifetime?
If the genetic variant is definitively pathogenic, then we will keep the patient. Then they're left on the drug lifelong.
Now, what I found a little bit puzzling is if I look into the epidemiology. Epidemiology that I found was that there's about 2 cases per million in incidence and about 3.3 cases per million in prevalence for patients over 8. And if I normally look at diseases, then it's normally a factor of 1 to 10 between incidence and prevalence. So do aHUS patients have rather short life expectancy, or are